Ever wondered what happens when the electrical impulses in your heart take longer than expected to travel from the atria to the ventricles? This is called an AV conduction block. It's a fascinating phenomenon where the heart's rhythm can be affected due to a delay or obstruction in the heart's electrical pathways, particularly when the PR interval exceeds 200 milliseconds. Interestingly, this condition is often found among otherwise healthy adults and doesn't usually necessitate treatment. Understanding the different types of AV conduction blocks can help diagnose and manage them effectively. Let's delve deeper into second-degree AV blocks, where some atrial impulses fail to reach the ventricles. This blockage is a curious condition, as it doesn't follow an all-or-nothing pattern. Instead, it's a game of ratios, with the number of P waves to QRS complexes varying, and as this ratio increases, so does the severity of the block. Now, the second-degree AV block is further subdivided into Type 1 and Type 2 blocks, each with its unique characteristics. Type 1, also known as Mobitz 1, is characterized by the Venkabach phenomenon. Here, a gradual prolongation of the PR interval precedes the failure of conduction of a P wave. This block typically occurs in the AV node, which is considered proximal. It can be triggered by an increase in vagal tone, for instance, following surgery, or RCA-mediated ischemia. However, it's important to note that Mobitz 1 is not an indication for temporary or permanent pacing. On the other hand, Type 2 or Mobitz 2 presents a different picture. The PR interval here is constant, with an abrupt failure of conduction of a P wave. This block is usually distal to the AV node, that is, in the His bundle. An important point to remember is that Mobitz II carries an increased risk of high-grade or third-degree AV block. Getting to grips with the nuances of second-degree AV blocks is crucial for accurate diagnosis and treatment. Moving on to another intriguing condition, the 2-1 AV block, and the most serious of all, the third-degree AV block. The 2-1 AV block presents a unique challenge. It's often not possible to determine whether the block is Type 1 or Type 2. This is where the role of prolonged or repeated recordings comes into play. These recordings can shed light on the nature of the block, providing valuable insights that could steer the course of treatment. But now let's delve into the most severe block, the third-degree AV block. This block is characterized by a complete failure of conduction of supraventricular impulses to the ventricles. In simple terms, the communication between the upper and lower chambers of the heart is completely cut off. When we examine the QRS complex in a third-degree AV block, we find that ventricular depolarization is initiated by an escape pacemaker distal to the block. The QRS can present as narrow or wide, indicating a junctional versus ventricular escape rhythm. Looking at the PP and RR intervals, we observe that they are constant, but the PR intervals are variable. This reveals a disconnect in the heart's electrical activity. There is no relationship between P waves and QRS complexes, as if the P waves are marching through independently, oblivious to the rest of the heart's rhythm. Managing a third-degree AV block requires a strategic approach. Electrical pacing is often used to regulate the heart's rhythm and ensure adequate blood flow. This intervention can be life-saving, restoring the heart's normal function and preventing serious complications. As we wrap up our discussion on AV conduction blocks, it's clear that understanding these conditions is vital. They present unique challenges and require a keen eye for detail, but with knowledge and experience, they can be effectively managed. With a comprehensive understanding of AV conduction blocks, one can better navigate the complexities of cardiology.